I put the slide in every talk that I present because I think it has a huge impact, or should have a huge impact, on how we treat. Adolescence is a very dynamic time period. A lot of things happen: growth, puberty, social development, emotional development, and accruement of bone density. And IBD cuts into each and every one of those. There is no recovery once you're past this stage if these processes were in any way held back by the inflammation. So time and again, this has to be a key focus for us when we treat our patients. Here's what we learned so far in pediatrics about nutrition. This was a study, and again, most pediatric studies tend to be smaller. That's a limitation we understand and we live with. However, this study randomized patients to receive either exclusive enteral nutrition for at least 6 weeks, and that was with polymeric formula, and had patients receive corticosteroids for induction in the second group. And what we saw is very comparable clinical improvement, very high remission rates here. What we also saw is that when you use nutrition versus steroids, there was a big difference in terms of growth failure. When you use steroids, 1 out of 4 patients remained in growth failure. When you use steroids, as we know, you set the stage up for steroid dependence. And if you happen to move on to a TNF antibody after your induction, you actually had a better response if you had your induction done with enteral nutrition. So perhaps steroid had a negative effect on the course of IBD. Nevertheless, resection rates were similar. So EEN, or exclusive enteral nutrition, does have its own limitations.